Welcome to the Athletic Shoulder podcast powered by Informed Performance. My name is Ben Ashworth, and on the show today, a very familiar face to me and to all of the Athletic Shoulder population is Gus Morrison. Gus, delighted to have you on today.
Thank you for having me.
So Gus, for the listeners that don't know about you, can you just outline a little bit of background and kind of your journey to where you've come to today?
Yeah, so obviously we met when you were working at Arsenal. The reason for that was I started to do my UKSCA accreditation coming from a physio background. And at the time, there weren't that many dual qualified S&Cs and physio. So I got put in touch with Ben. And since then, I've basically collaborated together on multiple projects. The first of which was my MSc project. So I was working at amateur rugby club at the time. Ben had done loads of his stuff around the ASH test, and I was like, well, I want to be using this test in the club that I'm working at. But like most amateur clubs, didn't have forced X. So looked at validating it against a SFIG, which was the first project we worked on. And then ultimately that progressed to looking at more testing around the shoulder and how we quantify certain characteristics, and we set up the upper limb or the shoulder assessment unit at the Institute of Sport, Exercise and Health, based in Tottenham Court Road in London. And over the subsequent couple of years when I was working there, it collected hundreds of patients worth of data, test, retest over time, and then correlating the changes in things like range of movement, endurance, strength and power against patient-reported outcome measures. Is the patient feeling better? And then when I left London a couple of years ago, came on board with Athletic Shoulder when it set up in central London, and been working with you pretty much ever since. Even since moving to Scotland, still been involved in Athletic Shoulder.
Yeah, perfect journey, and from very early on, it was clear that you possessed all that kind of dual qualification interest, which I think for most people working in this kind of area is so important, especially around testing and how that translates into training. And one thing that you've always been really good at is translating my sort of complexities and the brain and how I try and think about stuff and distilling it down into really practical solutions in terms of the testing approach, to the outcomes, and more importantly now, the application when we're starting to look at our online coaching processes and things like that, which all come back to our framework that you've helped to grow and helped to develop alongside people like Alex Wolf. So yeah, fantastic to get you on here. I suppose the journey's been a long one. We've known each other for about 8 years now, maybe even more. Where we've arrived at now, we've got a really nice framework. So perhaps you can outline from your perspective rather than mine, where you see us at the moment, any bits around that you think are kind of interest before we dig into a little bit more about how that might expand.
Yeah. So I think it ultimately comes from trying to understand good clinicians' thought processes. How when I was working before, a lot of the time, if I saw someone's shoulder injury, I'd be like, what would Ben do in this situation? It's quite hard to answer those questions. So then kind of going back to real basics and really informed by, I mentioned Alex Wolf so many times. I've met him a handful of times, but the influence he's had on my decision-making process has been mad. And the main thing is around that is the adaptation-led programming. So being able to tie that exercise prescription to the why ultimately of what you're trying to change. So then it's like, once you have that kind of component in place, it's like, well, how are we going to quantify that change, or even if it's a problem in the first place? And to start with, we broke that into 4 key buckets really of range of movement or mobility, whatever you want to call it. But ultimately, can they access positions relevant for their activity or sport? Probably more importantly, can they dissipate forces over a large number of structures rather than get jammed down into one area? So like a good example would be someone with a reduced flexion range of movement. If you can't get into a fully overhead position, but you're lifting overhead, your only option to get out there is just to hinge from your lumbar spine and shift that load onto your back. So you can't dissipate those forces across shoulder, torso, lumbar spine, hips. It's basically just going all into one location. Your ability to sustain force or repeat actions again and again and again without accumulating fatigue, so endurance or capacity, peak force or strength, whatever you want to call it, your ability to produce high levels of forces with no constraint on time. And then finally, constraining that time period. So saying, okay, you can produce high levels of force, but athletic shoulder obviously works predominantly with athletes. Therefore, in most athletic situations, your time periods to execute that movement is short. Tennis player hitting a forehand, or a rugby player making a tackle, or spiking a volleyball, whatever it is, you don't have 5 seconds to build up to your peak force. So then we've got, right, these are the 4 buckets of the measurable things. How are we going to quantify them? Once we have quantified them, are they good or bad? If they are bad, what are we going to do to change that? Do we trust that measure? So if it shows there's a change, my shoulder flexion range went from 130 to 170 degrees. Has it? Or is it just my measurement's so lousy that I get so much noise in that measurement, we don't trust it? And then it ultimately was stacking those 4 things on top of each other. And that's where that strength and conditioning background becomes quite useful, of periodization, which just seems an unnecessarily complicated word, to basically just say planned training. We are going to train range of movement either in this block, and then we're going to progress to endurance and then strength and then power. Or in a lot of situations, this athlete does not have 15 weeks to get back to their sport. So therefore, we're going to have to split that up across 1 week. We do mobility every day. We might do endurance Monday and Friday, strength Tuesday and Thursday, and a bit of power, whatever it is. But just having some structure to that training.
Yeah. And now we sit on a performance meeting every Monday, and I think, call me biased, but that has been really useful in, number one, grounding our decision making in the model, in the framework itself. And then also aligning, it's a marker-based exercise, which can seem to some people like a tick box, but what that allows us to do is work across those characteristics and say, look, are we missing anything? Is there something that we haven't achieved yet? And I definitely find that you bring me back to task on that really nicely. I think that's largely through the work you've done with online coaching, which I think is a really important part here. You've worked in not just shoulders, but also the lower body across ACL rehab. And I think that is, some of the insights from that have been really valuable to help us refine the application of our model and frameworks. Perhaps just give us a little bit of background behind that.
Yeah, so I worked on a research project for VALD. So it's the VALD Applied Research Initiative, where we would take measurements with people with ACL injuries at 3, 6, 9, 12 months post-op, basically plotting a normal trajectory. Then got involved with some management of those cases from an online perspective. And then I worked for a company called Strength Physiotherapy with a colleague that I used to work with in clinic, where it is 100% remote. I never meet the patients in person. So all the testing is done remotely, all the training is done remotely. And there are obviously positives and negatives. Your coaching of the kinematics is much, much harder, but the kinetics, you therefore just need to be really on top of. You ultimately just create very, very tight feedback loops. If someone, let's say we get an ACL patient in, they're 6 months post-op, we test their knee extension strength on the leg extension machine, and they're way below their target. The simplest thing to do is just sit them on the leg extension machine. And it sounds like really obvious, but there's no complexity to it. You just have a clear structure of how they're going to progress each session. And then you just take their, how many reps did they do? What weight did they do? What's their expected 1 rep max based on that? And is it going up, and is it getting closer to the target? And because they're doing that 2, maybe 3 times a week, the feedback loop I get on their testing it's like their testing is their training, is so tight. If it plateaus for more than 2 sessions, which is less than a week, I'll pick up on it and we can say, okay, have you literally hit a plateau? As soon as you get close to target, anyone who's done any strength training will know, like, you can't just add weight to your bench press, whatever, every single session. You get to a point where like this is genuinely as much as I can lift. We either deload, go again, or, put in like a supra maximal effort. So if the leg extension machine, if someone's getting close to their target, everyone tells me the target is too high and they hit it a few weeks later. Everyone tells me the target's too high. I can't do it. It's too heavy. My go-to is just eccentrics. Lift up with 2 legs. The weight must be so heavy you cannot lift it with 1 leg, but you should be able to control it down slowly with 1 leg. So we get a supra maximal stimulus, push those strength numbers higher. So I think the advantage from the online stuff, the big advantage is the real time feedback loop that you get. That if you see a patient in clinic, a lot of the time in clinic, I'll see a patient every 4 weeks, do their testing, set their program. I'm then blind for 4 weeks and they come back at 4 weeks later. So my feedback loop is quite large. Whereas if I see them online, it is, if I want it to be daily, it can be.
One of the other bits that you do really nicely, and I think you've collected a lot of information alongside the objective data, is the more of the subjective data, looking at some specific questionnaires and scales that you use. Perhaps, if you can just outline how that sits in and around the framework overall.
Yeah. So this came from starting the shoulder unit at the Institute of Sport and collecting all this cool objective data, and then finally getting enough data to be like, okay, I'm going to have a look at some of this, and came to the conclusion that if someone's stiff and you give them a mobility program, they tend to get more mobile. Someone's weak and you give them a strength program, they tend to get stronger. And that was pretty much my conclusions, which I didn't think were that interesting. So then I looked at some stuff around goal setting and planning again, and came to this framework of outcome performance process goals. So they basically dictate the amount of control we have over the goal. So the outcome goal, we have very little control over, but it is our overarching reason we're there. So then the vast majority of people working with a injured cohort will be their function. I want to be able to pitch a fast ball at 90 miles an hour, but I can't because my shoulder's sore. And pain. I want to be able to pitch a fast ball, but my pain limits me. So then we started to bolt on these ways to quantify pain and function. So the patient-specific functional scale, and a variation of a pain scale that we just made up, which is pain intensity, your numeric rating scale, 0 to 10, but then also how frequent is your pain and how long does your pain last for? So frequency, intensity, duration of pain. Take a mean of those 3 numbers and a mean of your 3 function numbers. So for a patient-specific functional scale, we ask the patient, pick 3 things that are important to you that is being limited by your injury or problem, and that one of them must be you at your 100%. So rugby, it would be, okay, making a head-on tackle, someone's sprinting straight at me and I have to nail them. That's your 100%. So that's one of your 3 things. We get them to pick 2 more and rate them. I can't do it at all, which would be 0, 10. I can do it exactly as I could do before my injury. So we get 1 number for pain, 1 number for function, and that's our outcome goal. Underneath that, we have our performance goals. We have more control over this, but these are the outcomes of their testing. So their range of movement, their endurance, their strength, KPIs, ultimately, key performance indicators. And then the thing we've got lots of control over is the process goals, and that's ultimately our programming. So if we have a rugby player who's like, I can't make a hit on my right shoulder, my function score is 3 out of 10, my pain score is 4 out of 10, where 0 is the worst and 10 is the best. I can't do anything to then just change their pain and function. But if I look 1 level deeper and I say, okay, you can't get into the position you need to make a tackle. You can't sustain force or repeat actions. You just fatigue really quickly. The amount of force you can produce even 1 time is rubbish, and it takes you forever to build up to that. Okay, what am I going to put into place to change those things? Okay, we're going to give you some mobility drills to increase your external rotation range. Same for endurance, same for strength, same for power, or RFD. And then we've got loads of control over that. because that patient or athlete can then go away and say, I know exactly what I need to do. I need how many sets, how many reps, what load, what rest period, frequency, the order of the exercises I'm doing, how that's distributed across a week. And then we tie, okay, if we push these numbers up of range of movement, endurance, strength, power, does it have a positive influence on pain and function? From the stuff we've collected now, the big driver of pain, for some reason, tends to be capacity as a driver. It's correlation, so I can't apply causality. But if we pull out all that information that I did a few years ago when I didn't have these patient report outcomes, now I can tie them back to the pain and function scores. So if someone has really low capacity, for example, that posterior shoulder endurance test is 20 seconds, and then we push that up to 75 seconds, those are the tests that seem to correlate the best with improvements in pain, which is more interesting than if I give someone a strength program, they get stronger.
Yeah. And actually, the bit that gets skipped is not evaluated particularly well or consistently across multiple people. It's low tech, so people can do it without access to all the kit.
No tech. Don't need anything.
Yeah. So I think that's interesting, and certainly the numbers that we've driven. Is that also something that you see across lower body too?
Yeah. So if I break it down, it is just consistent across region pathology. The big hitters are of those buckets is capacity, and then they're less relevant for this cohort because everyone is athletic. But the big predictors of whether you will get improvements in pain or function is ultimately how much you exercise. So when we look at someone's exercise levels against the NHS guidelines, if you meet or exceed them, you're much more likely to improve in either of those two metrics than if you don't. So for people working with sedentary cohorts, job number one, move. That's not the cohort with which we work, so it's not really relevant.
Yeah, it kind of lines up though with understanding the athlete's state, doesn't it? So, we might vary our expectation on someone who'd grumbled with a shoulder problem as a goalkeeper for months prior to actually having a surgery at the end of a season versus someone who's had an acute injury and then gone straight in for surgery, and therefore they haven't had the chance to atrophy or waste away and conditioning levels have dropped off. So that still lines up, I think, with kind of their current state at the time of assessment or the time of our intervention.
Yeah, I agree. And then no matter what you do, I think everyone's always going to criticize, or not even badly, but constructively highlight that, okay, you're measuring everything, but not everything can be measured. Can't remember what the quote is. Not everything that matters is measurable, and not everything that's measurable matters, or something like that. So then the bits that come less naturally to me are the stuff that isn't measurable. So the bits that prompt me to start to look at that, and it's not something that I think I'm particularly good at, but if I see someone who I've taken through that process, and they can access positions, they can sustain holds or repeat actions, they can produce force, and they can do that quickly, but I still say, okay, that's all well and good, my shoulder's still not feeling great. That's the bit where I start to think, okay, I'm starting to run out of ideas here, because we're now into this kinematics, coaching, proprioception, motor learning type of stuff.
Yeah. What a segue into motor learning. I think just to touch on, we had a client, again, even just constraining it within what we've already discussed there and what you've discussed. We had a client who was smashing all the numbers, rugby player who, killed it for RFD, for his body weight, size. He was doing unbelievably well. History of repeated dislocations. Again, when these are the sort of indicators, if we look back on some of the people who haven't particularly had alignment between physical markers and subjective markers along the way, they probably had some things that line up, like previous history of failed surgery. When I say failed surgery, not the surgery itself necessarily, but the ability to get back after a surgical intervention. That can and sometimes has been aligned with hypermobility. So actually genetic inability to create stiffness and protect a joint in space. There's a few things that line up there. We had this guy, this rugby player, who had progressed through all the markers, but still, when he went back, he would often break down at that critical point.
Yeah.
And I think that's where the framework, we decided, didn't we, that we needed to extend that framework out into the technical aspects, and that kind of return to sport phase, which is where we started to build levels for return to contact collision.
Yeah.
And those were the things that were missing from our physical gym-based preparation framework in terms of returning them to that ultimate outcome of, their patient-specific functional scale outcome.
Yeah.
I think that was a good process for both of us to go through with a really good technical coach, Richie Gray, around contact collision. But it also helped that athlete, particularly who'd failed a couple of times getting back, to give him the confidence. And that's what it all comes back to, is like, yes, physically we can build them to the point where we can see that we're more confident, they're more confident, they're going to be able to tolerate the demands of the sport, the needs analysis of the sport, the actual action. But then how do we plot that course from A to B?
Yeah, because it's the same in lower limb stuff, that ACL research is like, you might pass all these tests, but you're in a highly controlled environment, a planned task with little to no external confounders. There's no stimulus. Jump as high as you can on this metal plate, and then, okay, you're good to go back to sport. And that's we basically took McTab and a control to chaos theory and then applied that to a rugby context. And that was super useful for motor learning, skill acquisition, confidence, because the gap between, if we look at that gym-based framework, the end of that really is kind of RFD-based training and testing. And the testing will be lay on your front, put your arm out to your side, and push into this plate as fast and hard as you can. It doesn't look anything like playing rugby.
Yeah.
So all we've done in that gym-based training is that we've removed the barriers that potentially could contribute to you being able to enter and execute this framework from a technical standpoint. But neither me or you are a rugby coach. So I'm not the person that you want standing over you being like, you need to change, the angle of attack that you're coming in here, or, you're hitting same foot, same shoulder. Even just 3 hours Richie, I learned heaps, but it just highlighted to me, like, there's a lot that happens after that gym-based testing and training.
Yeah, and there's a potential technical reason why people are breaking down, which falls outside of the framework, but sometimes aligns. So if you talked about kinematics there, I think, where I tried to break this down originally was, tissue health, kinetics, kinematics. And that was after some discussions with Jared Anflick around what he does with NBA players with their tendons. But that's an overview. And then we've got the structural elements. We can use tests that we can identify what someone's state of their tissues are and their tissue health, and that could be a diagnostic piece. Then the kinetics is kinetics. It does exactly what it says on the tin. But the kinematics, there's biomechanics, and then there's technique, and that's where you need skill-based coaches with experience to produce technical models. So again, we're coming back to a model, and there are different technical models within each sport, within each task, within each action. But trying to break it down at least creates a discussion point of like, are they doing this well or not? And is that the limiting factor to them coming back to their confidence to be able to perform at the level that they need to perform at? So that's a simple version of the framework and the extension of the framework. The more complex piece, which you were segueing into, is this idea of how do we work out when the framework isn't working or isn't necessarily aligning to progression, or when we've plateaued and it's not a physical construct that we're dealing with, where do we go? And I think that is much more complex. It is a little bit more art sometimes than it is science, but I think we can lean on some science to try and see where our framework aligns with motor learning based decisions.
Yeah, I think where it starts is quite scientific, because all we're doing no matter who I had in front of me, I'd still want to test those components. And I'm ultimately trying to disprove a hypothesis of your pain is due to limitations in capacity across one of those four blocks. I can successfully disprove that hypothesis, in which case I need to form a new hypothesis. This is where I get a bit stuck, because disproving those hypotheses is harder when I can't then. And as you mentioned, like those skill-based tasks vary depending on the sport, position, the skill, ultimately. But even within gym-based setting, there's plenty we can look at and say, that looks a bit funky. But yeah, as you say, we're now into this, we're not measuring it. We're into kinematics and is there much overlap between that and symptom modification?
Yeah, the symptom modification in terms of actual, like, are we talking approach here, or are we talking just reducing pain?
The approach, kind of your classic Jeremy Lewis, or the one that I use all the time is kind of scapular assistance test.
Yeah. So those I remember writing those on my whiteboard as key parts of my overall assessment. I'd have Anne Coule's impingement algorithm and how that patient or athlete looked through that to give me some decision makers and guidance. But then Jeremy's very simple stuff around the scapular assistance test, scapular retraction test, some stuff around the thoracic spine, and then in his kind of conceptual framework, addressing humeral head position. Like, I can think of a client we're working with at the moment who prone handheld dynamometry, external rotation, peak force assessment, limited by pain, 70 newtons threshold, put a towel underneath his scapula, suddenly goes up to 110. So what have we done there? That is ultimately symptom modification procedure. Hypothetically, have we created a change in humeral head position? Probably not in my thought process. I think more around alignment of basically ball and socket. I think more around the alignment of scapula and the orientation of that, and how that then glenoid then faces the humerus and aligns with that to improve length tension relationships across the joint. And that's really meaningful for force closure. And I think then when we start to think about all the components around force closure and joint reaction forces, which is Simon Lambert's big work, which is another heavy influence, I think, on the two of us. Super bright. But if we can start to think then of all of the breakdown around that, structure, yes. Surface area of contact. So is there damage to the glenoid? Yes or no. If there isn't, all right, is there damage to the cuff? Yes or no. But then one of the big things in there is the sort of rotator cuff force and that compressive force to stabilize. Plus, and he's extended this because I had a chat with him over dinner last year, but the neural system and the influence of the neural system. So all of those things, and by the way, the equation is JRF equals SAC.
Yeah. Plus rotator cuff,
RC,
NMSLP, neuromechanical labor. Yeah. I can't remember what it stands for. Yeah.
So that sounds really complex, but all it does is it breaks down that force closure element. And so for us, it's exactly what we're trying to look at. For me, when we're looking at motor learning, we're not trying to look at necessarily how someone moves under low force in positions that don't replicate the challenge and demand of the sport or the injury prevention mechanism. We're trying to take that down the road of looking at motor learning as it applies to those key outcomes, which of course again means we're going to have to look at progression towards that point, but we are going to have to look at regression back to someone coming out of a sling or someone having ripped the pec off a bone to the point where they then go back. Now, everything therefore is under the banner of motor learning. Strength training is motor learning.
Yeah.
So it's being specific around the stuff that then doesn't align in that kind of linear pathway of progression for strength, endurance, range of motion, and rate of force development. And falls in our framework under the banner of kind of coordination of force. So we're limited by things that would restrict magnitude of force, rate of force, or coordination, timing, sequencing of force. Those are the less measurable things.
You can get some kind of information out, because if we did, if we measured everything and there were we were like, everything looks good. But when we do a coordination-based task, sequencing-based task, so for example, a landmine throw, where you've got the end of a bar in the landmine attachment, and your aim is to throw that as fast as you can at any given load, and their scores were really poor on that test, I'd familiarize them, because there is a skill to it. So the first time you do it, you might just be rubbish at it. But if it was a genuinely bad test, we're like, well, you can access the positions, you can produce the force, you produce it at an adequate rate. So therefore, it must be a coordination-based issue. Or that's where our thought process goes. What are the key interventions there then? Is it just to do that test more frequently, or you give them a regressed version where they need to either do it in a position that's relevant, at a magnitude that's relevant, or a rate that's relevant to the task?
Yeah, because I think that idea of how someone, it's a bit like I think if we look at this as a sort of up-regulation, down-regulation of muscle activity and kind of redistribution of muscle activity around a joint, if we're thinking about even just as locally as the rotator cuff. Now we can, in a simple form, go direction-specific deficit in internal rotation or external rotation and what that might mean to us. But that also, when we're looking at the ratio of force output, that might give us a little bit of a lens to that coordination of force to then create stability. And I think when we're coming back to looking at the athletes that we see, we're not talking about people who've had necessarily frank nerve injury, on a sort of Sunderland scale of progressive nerve injury that may take, up to 12 weeks, or may take it where the axon has been damaged, up to an inch a month regrowth, a millimeter a day. Those are really difficult to start to understand in terms of how we might coach and train that and re-educate that, versus the rest on the spectrum, anything from there up to normal in terms of recruitment and muscle activity and redistribution of muscle activity around a joint. Like, there's some pretty good EMG work, the surface EMG, for all its limitations, from people like Karen Jin, who've looked at normal patterning. And as you load up, there doesn't tend to be a difference in the muscle pattern as you increase loads across a joint. But if you've got significant inhibition, either due to a structural deficit which leads to compensation, or through an inhibition, whether that's a higher cortical center mapping that stops people recruiting a specific muscle. Let's take the subscap, for example, in that force couple across the joint. Then once you stick force above a certain level, that meets the threshold of your ability to produce force through subscap to stabilize. That's a product of the cross-sectional area or the size, plus your ability to access those fibers. And if we simplify it down to that, well, you'll reach a point at which the magnitude exceeds the capability. And you've got only one option, which is to cheat.
Yeah. So if we stuck with that example and said, okay, we've got someone who's got this IR deficit, or even if they don't, but if they didn't have that on their testing, so if we looked at their peak force into internal rotation and they generally look pretty good, and let's say we even did it on a isokinetic machine, so even through range, it all looks quite good. Does that still then apply when we start to stress them in a slightly different position, open task and external stimulus? So they've got to concentrate on something else while still doing this.
It definitely applies. I think the ability to nail the cuff isn't just about being, supported IR. I mean, as you know, I'm not telling you anything here that you don't already know. The ability to load IR consistently is not nailing the cuff. It's then about multiple planes of movement, multiple angles, different ranges in the arc to enable them to access things across different positions. Because there may be some sort of carryover from the apprehension of the position that they injured themselves in.
Yeah.
They can produce internal rotation force in abduction at 90 degrees, 0 rotation. But when you take them into that 90 degree rotated position, it's going to be harder for them to produce force there anyway.
Yeah.
But on top of that, they've now got this potential down regulation of their ability because of inhibition. So then building confidence in those positions, reminding the joint that it's safe to go there is a huge, and that can influence massive change. I think, going from almost fork to table, from like plinth to gym-based exercise. We see all of this, don't we? We look at someone and we look at their apprehension test on the bed.
Yeah.
And there are times where you would say, well, if they're apprehensive on that test on the bed, why would we then be going in the gym to load them? But there are times where that re-education and training, probably through some on-bed based ISOs, through range to build confidence, can lead within one session to them being able to load into external rotation.
Yeah.
And then that will influence their apprehension test in a positive way. So those kind of pseudo apprehension tests, I mean, the population I go back to there that I learned a lot about this from was judo. I mean, we were seeing probably 4 every randori, 4 every fight session. People would come in and you'd look at their apprehension and they'd be inhibited going into those positions after, and yet that would settle very quickly. So the association between a structural damage and a change in recruitment or a change in someone's pain, that there's often minimal alignment when we look at the literature. Yeah. So we have to then have a lens through which we can explore progressively challenging someone. And that's what we basically do using the framework. But I think inside that framework, there's a confidence building. It's understanding the levels of what we're applying. It's understanding the principles around moving from safe zones and protected zones into more challenging, chaotic zones.
And that fits what was on the performance call this morning of the best way to push someone's test score up is to mimic the test as closely as you possibly can. So if we had someone with a internal rotation strength deficit and we were testing them on the force frame at that 90 degrees abduction, 0 degrees external rotation, the best way to push that number up, if that was your objective, would probably be working through the super specific range in a supine position on a cable, potentially even eccentrically, so pulling down and then lowering back. But then you've not challenged them. So you will push internal rotation peak force up by doing that, provided that the load is sufficient and you overload it over a period of time. But what you're not going to necessarily do is build any confidence in this position where their deficit genuinely does exist. So from a gym-based progression, we can absolutely keep this super specific range in here. We probably want to explore something here and we can regress it as appropriate. So it could just be like in a doorway, like a pec stretch, just ISO push. So there's no risk of them going too far back. You can build them off a block and do that kind of internal rotation dumbbell ISO hold through to eccentric back to the floor, through to potentially eccentric beyond the floor. If you prop their elbow up on a yoga block or something. So then you've got that continuum of we've increased the amount of range. So we've now made this training more position specific. However, the magnitude we probably need to, after that would be the next one. Okay, you can get into this position with a light dumbbell, but we want to stress you with a decent amount of load back here. And then finally the rate. And that would be either kind of your cable catches out in these long lever, not that traditional abduction external rotation, but a Y position, the kettlebell decelerations. kind of throwing out and catching here,
Yeah.
and then drop and catching. And then you've kind of said, okay, well, we've hit the position of your symptoms. We've hit the magnitude of force relevant for your sport, or as relevant as we can make it. And the rate, again, as relevant as we can make it. And then at some point, if that's a thrower, that's when we go into that. We go and speak to Will from British Baseball and say, we've got this framework of building out your throwing capabilities through these highly constrained variations, which actually overlap hugely with what we do anyway. Position-specific isometrics, which we just discussed, of like the position, the magnitude, and the rate. But then high constraint variations, so sideline throws or kneeling throws, med ball variations, then unconstrained variations. So now we're into proper throwing mechanics, and that then is kind of outside the scope of a physio unless you're also a throwing coach.
Yeah, coming right back to that sort of motor learning piece around these particular cases, and again, same example, I tend to choose now eccentric loading supported as my go-to IR strengthening exercise.
Yeah.
And the reason is not because it's eccentric and therefore it's a potentially higher force. It's because concentric patterning tends to get people who have this deficit to lead with the shoulder.
Yeah.
And timing and sequencing then becomes an issue. So we can't ever, I think it's Eric Cressy said, no one ever gets injured when they're standing still. So therefore our postural assessment is quite limited. I'd agree with that. I've looked at Jeremy Lewis, measuring, position of scapula lying down supine on the bed. And again, I've done that. But when we look at how that translates into someone moving, that's really interesting. So do they shorten massively through the anterior part of their scapula, which already changes the length tension relationships negatively for subscap acting over the front of the shoulder joint to produce internal rotation force? Well, that means that usually concentric based actions that are dynamic tend in those people who've got that shoulder limp to drive it from the scapula.
And the best example of that, in my opinion, is anyone who's either done handheld dynamometry testing or force frame testing at 90 degrees abduction, 0 degrees external rotation, and got someone to push as hard as they can into internal rotation. Because if you don't quality assure that, anyone that you do that with will end up either adducting their arm or shortening the distance between the coracoid and the step.
Yeah.
And doing it, all roads lead to Rome. It is exactly the same problem as you just pointed out. So yeah, I think an eccentric one, it actually opens that distance up.
Exactly. And that's the reason why I use it from a, not necessarily loading principles, but from a movement pattern and getting the scapula out of the way and not arm wrestling the movement.
Yeah.
Critical things, again, coming back to what we're trying to achieve. We're trying to set up the optimal position for force transfer and joint reaction force. We're building the foundational base of the scapula to then allow us to work the cuff, the old classic cannon and canoe, that's where I start to see most of the coordinative issues are driven around that kind of very complex interaction of the scapula, the trunk, and the arm.
Yeah. The things that I go back to that you said ages ago is the distance between the coracoid and the sternum, and I don't measure it, but I just observe it, people dumping their shoulder forwards and keeping the arm connected to the trunk. And the best way that I found to kind of view that is kind of a half kneeling chest opener. So if you get someone next to the wall, front foot is furthest away from the wall and something between their front knee and the wall itself to keep their pelvis kind of square on. And then you ask them to open up through their thorax. So you're trying to increase the amount of torso rotation they have. At some point, they will dump their arm behind them to gain that extra range. And they lose that connection with the humerus and the torso. And they create the same problem as that dumping into internal rotation. You're just lengthening through subscap, disadvantaging it from a length tension relationship. And then it can be as strong as you like in this position, that test position, but you've created such a disadvantage, you're probably never going to overcome that.
Yeah, and rugby coaches will look at that, and you're leading with the point of the shoulder. You're making yourself much more vulnerable. Rowing coaches talk about leaving the arm behind them.
Yeah.
Again, similar. It's in the language if we listen to good coaches and what they see and how that aligns probably to injury propensity in the people that they work with. And even then, when you're talking about that test is just a limb base. There's not much load going through the shoulder there. So how does that, if that's happening at that level, how's it then translating at high force, high speed?
Yeah. All that is telling me is like, is there an obvious reason why they're leaving their arm behind? If their thoracic rotation, on that lumbar lock rotation test, 64 degrees from the 5 study in swimmers. So we're going to say about 64 degrees is normal. You see people down at 40. And then for me, it's like, you can do as much motor learning stuff as you like. It's not going to change anything because you physically cannot access the position.
Another way of thinking about when something isn't working is like, I remember the ice hockey girl who had a weak internal rotation test. I gave her what should have been a strengthening plan for 2 weeks, and she came back much worse. And it's because it just went above that IR threshold again. And so she just got better at compensating.
Yeah.
And actually, it took me to get her thumb in her armpit on the subscap, doing some like mid-range ISOs, to then start to actually get some loading specifically through the target tissue to then create an adaptation to drive that up. But her limitation was the redistribution of muscle activity around the shoulder girdle.
Yeah.
To create stability, which was the task at that particular high force threshold. So that's another example of motor learning. I do think we need to touch on a little bit about RFD, but also, like, I suppose just ask me some questions, mate, and I'll see if I can answer them. But it'll be more about how I practice and think. I think specifically that Y shape and the L shape are two tests that I use to look at strategy of scapular load.
Yeah.
The ASH test around same stuff is, what do we see in terms of normal compensations?
Yeah. Okay.
Yeah. So those things sit within our framework. So I suppose let's go to that, and you can just ask me some questions.
Yeah. So if we're looking at the quantifying this, it's obviously much harder. Should we try and test these things around motor learning, or the bits that are typically harder to quantify? The stuff that I always come back to is the scap. It's impossible to quantify scap movement or dyskinesia. Are there any go-to tests that you look at for scapular testing or their ability to transfer force from proximal to distal?
Yeah, I think always, as we've already covered, the quality assurance about when we're asking people to transfer force across the shoulder, particularly at high threshold with some of the tests that we use, we look for these compensatory strategies in and within those tests. We also look at that across their gym-based rehab all the time. We're looking at trying to coach what we see as being more optimal movement strategies. And the test tends to carry over to the training tends to carry over to the sporting action itself. But the couple of tests that I use that fall probably slightly outside the framework, firstly, a prone Y hold. So this is used loaded by a lot of baseball pitchers as one of their warm-up exercises. But I think again, if we add a little bit of load to the system, when we've got someone lying prone on their front, we get them in a thumb up Y position and we ask them to just hold their limb there. What we see often is a couple of things. We either might see an internal rotation, so they can't keep their thumb pointing upwards. That tends to point towards perhaps a pull towards internal rotation at the glenohumeral joint. We might see that the scapula adopts more of an up and in strategy. Now, that's really common pattern for people who've come out of a sling. And we see essentially the usual suspects, the left scap driving that up and in pattern, the rhomboids over retracting and over pulling to try and lift the arm weight. But what that then brings is this combination of the scapular destabilizers. So we see dominance of pec minor. We see dominance of lats, teres major, dominance of and redistribution towards lev scap based strategies. They're all downward rotators and scapular hitchers or depressors. Now that means that we can't get the socket into the right space to be able to, create a stable base.
It's not upwardly rotating.
Yeah. So whether it's a global strategy that affects the scap or whether it's a local issue at the glenohumeral joint, we can see that. And sometimes they'll be able to maintain that with high effort physically for the fact that they're just lifting their limb.
Yeah.
But we then might see that the pelvis rotates towards the affected side. So they are trying to shorten through lats to try and again create stability, which is ultimately what the body's trying to do, is to trying to create stability at the glenohumeral joint and across the shoulder girdle. And so we've got to have an eye for all of those things, because if we don't control for those when we come to setting exercises or testing, athletes will cheat and then we'll get these false readouts of good results.
So when you say you test this is a qualitative test rather than quantitative?
Qualitative.
Okay.
This is a qualitative coaching eye.
Unilateral or bilateral? Because we've all seen on a GHD the YT view exercise. Is it a bilateral exercise?
This is put the left in an L shape, provided they've got the range to get there at that kind of 90-90 position on their front. Put them in that position and then ask them to hold it.
Just the weight of their limb.
Just the weight of their limb, then test the other side.
Okay.
And the difference is important to record, not only in what you see, but also in what they feel.
Yeah.
Wow, that was a lot harder on that side, combined with some pelvic rotation and or some scapular hitch or change in position of the scap.
Yeah. And in terms of hold times, you're saying you're better off loading it ideally. Did you go off the general rules of that kind of posterior shoulder endurance test? Is it similar? Ballpark 2% of body weight, ballpark 75 seconds. Because I do the same thing when I test quantitatively of the stopwatches running. They've got 2% of their body weight in this T position unilaterally. But I see exactly the same thing. Someone might be able to get to 90 seconds, 75 seconds, but they hitch up the shoulder, or they rotate through their torso, or their pelvis starts to rotate. And often people will achieve the same output on both sides. But one, their strategy is quite different to achieve that output. And two, the RPE, I don't record it formally as an RPE, but exactly as you just said. Oh, my right side was 10 times harder than my left, even though if you just look at the raw number, it'll be like you hit 75 seconds on the right side and 73 seconds on your left side. There's no real difference.
Yeah. And if they can't do that L shape or Y shape on the bed, when we then put them in a capacity-based test, it would be a huge surprise to me if they could then sustain, those positions
without huge cheats,
without huge compensation.
Yeah.
And so that's why I do it is a gate, an entry gate. But my lens through which I look at this is recruitment around shoulder girdle. Ultimately, we want serratus and traps to be able to do their work to provide that stable base and not be destabilized in terms of getting into an appropriate position. If you think about that, often people then coach that and go, well, just think about this muscle or that muscle or this muscle. For me, the way I coach it is I go like push out, work out wide, push out through your fingers in that position. And that tends to facilitate more of an external focus when they're going into that re-education of the position.
Yeah. I'm assuming this is post establishing they have the range to get into that position. Otherwise you are largely wasting time.
Yeah. Yeah. They must be able to get into that position.
Yeah.
So the 90-90 or the Y shape. The Y is nicely aligned from a functional anatomy perspective with lower trap, mid trap bias. And some of the original EMG work around those kind of prone Ys for the biomechanics of how the clavicle rotates into those positions, but also the muscle activity that's happening through scap and posterior cuff in those positions is the reason why I like that. And again, though, that's another area to work on, because if they can't get it there and we then start to load up the system, my concern is as we load things up, they're if they look like they're doing it really well, they probably aren't. They're probably cheating. They're probably setting up, even if the shoulder girdle isn't being pulled out of position, a huge pull in the wrong direction that they're trying to fight.
And then you end up in that situation where you're reinforcing these motor patterns that you don't necessarily want.
It's a struggle, isn't it? And then, well, why are they being, forced to change their strategy? Is it physical? Is it? And I think this is where it comes in around the up-regulation, down-regulation. So the tone, the resting tone, protective spasm. There's some lovely work around muscle patterning that's been done in more extreme cases by Andrew Jaggi and Simon Lambert from Stanmore. But does that give us a framework through which to assess? And I think that's what we're trying to do here. We're trying to bring it down into shapes and positions that the normal human should be able to get into, that if we put them there, we'd love to be able to see them yes or no, hold or pass. And if they can't do it, can we train them or re-educate them so that they can? And if they can do that, great, we can then start to progress them. If not, we need to spend a lot of time around regrooving motor patterns in a simplistic format, which means practice at the appropriate threshold, very focused practice on trying to achieve a position and shape. That then doesn't translate into the higher force, higher rate task. We've got to build the pathway that then, appropriately progresses them through those levels, whether that's through our coaching in the gym or whether that's through technical coaching models on the field.
Yeah. And then, to go back to the initial framework of those 4 key domains, within those domains, you're still quality assuring 1 each test, 1 each exercise, and you're trying to make sure that you are getting people into positions that aren't big hitters, are shortening that gap between your coracoid and sternum, elevating or hitching the shoulder girdle to get it into a position where they can produce some kind of force, or dumping the shoulder forwards for exactly the same reason as that. Like, it falls under this one really, doesn't it? The coracoid to humeral distance. So if you've worked through those 4 buckets, while quality assuring tests, while quality assuring exercises, no matter how well you've done that, if that person's going back to a sport, that's when we start to introduce chaos or, these external variables of other things happening, where we go from a closed skill in the gym to a widely open skill on the field or the pitch, whatever they play. And that's where we've got these kind of return to play pathways for athletes and coaches to progress through levels of complexity return to sport. Because it's not a case of I've smashed my ASH test 2 position, I'm now good to go back to nailing people.
Yeah, that's the misconception, is we set up these tests to pass these tests and therefore that's what we do. The art is in getting people to be able to pass those tests with good strategy.
Yeah.
That is where the expert practice and applied work comes in. And I'd love to say that's entirely ingrained in science, but it isn't, because we've got the individual response. And so the N=1 becomes quite important. I think, one of the things we've spoken about is, it'd be lovely to have an external focus and control work out wide. But if someone has never felt where they should be feeling an exercise, and there are some, for want of a better term, motor morons who have no body awareness versus those people who are super intuitive. Again, that's something that we need to identify. Are they trainable, coachable or not? And how is it best to coach them and train them? Well, actually doing an ER exercise and they're feeling it anteriorly when we want them to feel it posteriorly, just simply about tapping the muscle or putting a finger on the muscle, going, this is where you should be feeling it, can be the thing that changes.
There is some science in that.
Recruitment. Yeah.
If you repeatedly tap where you want them to feel it while they're doing the exercise, you'll improve the amount of activity within that muscle.
Yeah.
That's where the downside of online stuff is. For the people who lack capacity, if anything, I'd say online is potentially better. But for the people who lack skill, it's very difficult to get that, not being in the room next to them.
Yeah, and I've been into various elite organisations, and one of our tests that we use, low tech, is the ISO hold at 10% body weight in the hand, for 10 seconds, and we have a look at the RPE for that. So RPE will give us a good idea around the effort, the physical effort required,
the efficiency, input versus output. Their output is 10 kilos, but their input might be 10 out of 10. So therefore their efficiency is 1. 10 divided
so
by...
that's one thing in itself that gives us an idea around that efficiency, which you could see as a lens through which we look at kind of motor pattern and how effectively they're utilizing the muscle for appropriate for the task. So intention becomes important. But the other thing is, you give that to 70% of people, they hold it there, they go, yeah, I feel it at the back of my shoulder. That's great. I've never felt it there before because I was dealing in pounds, not kilograms. But then there's the 30% that go, no, that lights up my neck up here. That hits me at the front of my shoulder. And I remember actually being in one training room, and we had to get a guy kind of in prone in some external rotation, lying on his front whilst actually abducting his contralateral leg. So hip abduction on the side. And only that was a thing that took away anterior shoulder pain and left scap or neck-based feel, and was enabled him to hit his posterior shoulder. Now, we can talk all day about what that might have done hypothetically to, posterior oblique sling. We've given him some hip force closure, which allows his lat to let go, which stops pulling him into whole shoulder girdle depression, downward rotation, glenohumeral internal rotation. Possibly that's what it was doing. How then, how's the posterior cuff going to win the battle against all of that dominance?
Yeah.
It isn't. And that is what, I suppose, when you ask me, how do I work? That's hypothetically what's going underneath the surface.
Yeah.
To try and minimize the effort to try and target key areas that we know historically from the literature are areas that we need to be good at. So we do need upward rotation, posterior tilt to minimize pain and symptoms in the shoulder. We do need the posterior cuff to be doing its job to help decelerate shoulders and provide that kind of co-contraction and stability around the joint for force closure.
Yeah. I guess my final question would be, if I saw a patient and they had ticked all the boxes not from the motor learning perspective, what would your top 3, where was your first 3 things to look at? Because, for example, if someone referred me a shoulder patient and said, I've got this guy's anterior dislocation, they're going back to sport, but they're still getting symptoms, they're still positive on an apprehension test, my first things would probably be internal rotation. Do you have a big enough buttress across here to stop yourself, to stabilize there? Anecdotally, I found that lots of people are good here and then bad on these long lever positions. So I probably look at a Y position. And then the third one's a bit harder, but potentially a thoracic rotation. Can they connect their humeral head to their thorax? So lumbar lock rotation test, or an internal rotation range of movement. Because if they've got really tight posterior capsule, is it pushing that humeral head forward on the glenoid? But if we had ticked all of those, and then I would go to Ben and say, what are your top 3? Hypothetically, obviously you're not.
Yeah.
Fortunately, in real life, nobody's forcing you only to do 3. But for the purposes of this, are there any 3 big hitters that you're like, these are typically where I first look?
Yeah, I'll save the expected one till last. But the first one I'd look at is just that real simple L and Y shape.
Prone, the one you just described.
Yeah.
Can you hold that position?
Yeah. Because of how that gives me the lens into potentially the area of compensation. So is it local? Is it scapular? Is it more global in terms of that force transfer and coordination of force transfer? I think the second thing that I do use, and science doesn't sit particularly well behind the validity of joint angle reproduction, but it does sit behind reliability of joint angle reproduction. So I use a balance point test.
A joint position sense.
Joint position sense.
That's side lying up to here.
Sideline. Yeah. So close your eyes. We put you in a position on your side, the arm balanced above your body.
Yeah.
We take you out of that position with your eyes closed, and you have to reproduce that position.
Yeah. And then we use an inclinometer to measure. So for anyone who's not familiar, it's joint position error score. If you just Google that, you'll find it.
And that's from Andrew Jaggi and Simon Lambert as well. I stole that from spending a day with Andrew at Stanmore, and she used that balance point, which I really like. And as well, then the training is get a Swiss ball and balance it in that position, do a Turkish get up and balance something in that position.
The ability to keep the center of mass over the base of support. Yeah.
100%. But where that's given us some really interesting insight, and it doesn't, often it's the same right and left.
And their accuracy is outrageous. People will be able to replicate within 2 degrees. And then the problem with that is that the measurement error is probably larger than 2 degrees. So this comes back to should we be measuring this stuff? And how much do we trust the measurements that we're taking? Exactly.
And the thing is, when we've seen it go wrong is the interesting stuff.
Yeah.
So, for example, Ehlers-Danlos syndrome, multiple repairs in someone who's got floppy, sloppy collagen. After surgical repair to the anterior capsule to tighten it up, their joint angle reproduction on that balance point test, the arm went 30 degrees beyond the body.
Yeah, you don't need to be measuring.
You don't need to be measuring it, but if we hadn't looked at it, we wouldn't have known.
Yeah, I'd still look at it, but it's, what you were like, this is not a measurement error. This is catastrophic ability to know where your arm is at stake.
That is exactly it. And again, my lens through that is they've got no idea of where their joint is in space. Therefore, how can they then have any sort of motor output to stabilize that joint? And that was also something, again, if you look at it as a sort of diagnosis of exclusion, is if we've done everything else really well, we've tried normal training alongside our framework and it hasn't worked, well, we probably need to think and consider motor learning or motor control as the direction. So I remember a second row, he'd actually had, and these are some of the indicators, but he'd had a stinger. So he'd had a transient neural injury. But even after the transient neural injury had settled and there were no neck symptoms, he had a knock-on effect on shoulder function. He was playing week in, week out, but he was getting real neural type symptoms in the arm consistently because his cuff had been knocked out. The lower cervical drivers to the rotator cuff, the C5-6, C6-7 had been knocked out. So they progressed him pretty well using a very linear, stable-based approach, hadn't improved. We did the balance point, and again, big differences right to left, greater than measurement error differences right to left. The team then put in place a strategy which was much more earrings on bench presses, with kettlebells hanging off them, stability focused overhead perturbation type work. And very quickly, he was able to access his force. He wasn't weak, but he wasn't able to recruit and bias appropriately to then stabilize. So that was really interesting because he was performing theoretically, i.e. turning up on the pitch, but he was still getting symptoms.
Yes.
That was a really interesting reminder of how maybe that second thing, the joint angle reproduction, when it's wrong, and it can give you a lens that their proprioceptive feedback from the joint isn't good. So what do we do with our training? We get them to perform some sets with their eyes closed.
Yes.
Really simple change. Same exercise, different challenge and constraint.
Closed chain, open chain, side line, like lying supine, going into a sideline position with a kettlebell. Just heavy enough that if you start going wrong, it's going to start to drag you. Yeah. So those are your top 2. The L, L and the Y, number 1. Then a joint position error score. And the number 3.
Number 3, which probably should be number 1, is this thing called the ASH test.
Fair. So you're talking now about qualitative assessment during that quantitative test.
Absolutely.
Yeah.
Exactly what we're doing. So quantitatively though, I do think there are some pieces that sit there, but we'll come back to those in a minute. The first thing about this is, and I've said this before, and he even quoted to say it in my PhD thesis, of like, the ASH test is not just a shoulder test. It's a force transfer test from the point of contact across the shoulder girdle and arm into the base of support. And what that means is it starts to show how someone transfers force across into the trunk. And we've even seen how that links with kinematics of throwing around pelvic and trunk rotation velocity. So why that's important is because the threshold of the test is high enough to bring out compensations of elite level performers. We then can see 4 different buckets again. Shortening the limb, so bending the elbow, that's probably glenohumeral strategy. Dumping through the shoulder, which we've discussed. Again, that's probably more scapular-driven strategy. Rotating through the pelvis, that's probably more trunk rotation and force transfer, anti-rotation strategy and stabilization to provide the base for the scap and the arm. And then you've got kicking out through the base of support. And again, we think that more...
Creating a wider base of support. Yeah.
That might be around creating stability from the pelvis to then lumbar spine, trunk and upstream effects. So that in itself, I think, is interesting. It's demanding a test because we make it unstable. We put the other arm behind the back so they can't fix. And that brings out a qualitative component of this, which I think there's a project waiting to be done. Very difficult to put markers on. And we tried to do this on a isometric test when you're lying on the floor to see what changes. But visually, if you video it, we can see differences in one person right to left or one person 4 weeks ago versus them now. So I think there's some carryover and some stuff and some insight we can derive from that. The other piece, which is quantitative, is we're looking at structure or more kind of mechanical versus neural components of RFD and force. So if you give someone time to produce force, they'll be able to produce it even when they've got pain or they've got fatigue. Whereas if you give someone a blink of an eye to produce force and constrain the time window, pain and fatigue and other inhibitions, whether that's downstream, effects, they won't be able to produce rate of force fast enough. And that means we have to assess it in a window that's, 1, both reliable enough, but 2, sensitive enough to detect those changes. And that's the critical piece around this. I think from my own work, RFD isn't easy. It's not easy to quality assure good outcomes and good results that you can trust. That's the first piece. So don't even go there unless you've familiarized, coached it well, set it up, delivered it optimally, because you won't get what you need. But when you have done that, we can get good reliability of RFD even in those shorter time windows. And the optimal is probably around 150 milliseconds from the work that I've done.
And do you do force at 150, or do you do RFD between X and Y point?
There's multiple things. We use RFD 0 to 150 or RFD 0 to 100. But under the surface, we're still looking at like max RFD. We're looking at time to 80% peak force. Not time to peak force, which is massively variable, and the coefficient of variations are like 60%. But actually, time to peak force has a decent reliability ratio. Time to 80% peak force has a decent reliability ratio. Whatever we dial in on, what's interesting from the literature is that in a sort of very reductionist approach, that first 0 to 75 milliseconds is seen and deemed to be neural, although there is some structural component to it. And then beyond that is probably more likely structural. In my own experiences, measuring 50 milliseconds is hugely volatile and very difficult. Measuring 100, you can definitely see when you look at best rep, changes that are way outside of noise within the tests. So you see signal. And so I think it's worth capturing that as well as 150. When you start going up to a window around 250 milliseconds, it mimics peak force. In fact, it starts to correlate with peak force. That's not worth looking at. So I think the sweet spot is around 100, 150 milliseconds, not 50. And what that gives you then, to go back to the point of this, it's giving you neural inhibition. You know what the peak force capability is and whether they can do that, but how quickly they can access that is about taking up slack within the neural system to be able to then stabilize quickly under load or perform ball release, tackle impact, etc. And I think that's then a really nice bookend to our preparation phase where we go, our RFD is good enough, and then how that then applies across plyo push-ups. You know, how that applies across an internal rotation, external catch, a throw. We'll see that RFD and some of those velocity-based markers not as good on the injured limb and affected side, which again means that their human capability is higher than the capability of their arm. What is stopping them getting there? Is that structural, or is that more likely neural? And therefore, if it is, what's inhibiting them doing that? That is probably training RFD without cheating and compensating. So those are the sort of three, and they cover a lot of different things, don't they? They cover a low threshold, essentially very early capacity-based test. They cover a joint angle repositioning, and they cover a high threshold long lever test. Those would be my three.
Nice.
I think one of the things that is worth just you actually pointing to is the work that you've been doing, Gus, which is great stuff around benchmarks. So perhaps you can just give listeners a bit of a feel of that, where you're at the moment and where to look out for you there.
So basically following on from the work we did at the ISCH, then started to expand that into all joints, body parts. So creating systems where physios can do this with, if they don't have force decks, force plates, dynamometers. So the ability to easily capture range of movement, endurance, strength, and power data on their athletes or patients, correlate it against patient-reported outcome measures, and then compare to normative data. So, for example, if you've got a patient who's got a knee extension strength deficit, you can just carry those test results forward into a program builder that will then suggest a range of exercises rather than one specific one. So from super easy, like isometric holds, isometric pushes, concentric, eccentric, building into integrated movements. So compound movements. So it's available for, it's mainly aimed at physios, whether you're working in with face-to-face patients, or you can do remote-based testing as well. So if there's any interest, you can go to benchmarkps.org, or you can just email me at gus@benchmarkps.org or gus@athleticshoulder.com. So yeah, if there's any interest, let me know. But we've got a fairly decent number of users now, people using it in clinical practice, and we're able to pull that information out. So, rate of change, how quickly does shoulder external rotation strength change in your population? We can filter that down to just you, your clinical practice, or everyone. And obviously, like everything, the more information that goes in, the more insights we can pull out.
Yeah, brilliant piece of work. And something that Athletic Shoulder is leaning on as well, around some of those collection of data and how we look at change over time as an indicator. Really, really useful for us, but translates across all body areas, and definitely for a wider group of physios than just the athlete population as well. Really, really nice piece of work. So, Gus, it's been an absolute pleasure as always to have the opportunity to talk to you, this time a bit more formally on a podcast. But I'll probably see you in about 5 minutes to talk about some online coaching clients. But thanks a lot for your time, mate.
Thanks for having me on. Cheers.
Bye. Cheers, mate. Bye.